Welcome to Keeping Up With The Radiologists. This is a podcast from Penn Radiology. I am your host, Saurabh Jha. In this podcast, we will discuss issues related to radiology in particular and healthcare in general. We will express opinions, state facts, and have robust discussions. Thank you for listening, and I hope you enjoy it. Hello, welcome to another episode of Keeping Up With The Radiologists. This is Saurabh Jha, your host, and joining me is my co-host Mitch Schnall, Chair of Radiology at University of Pennsylvania, and a special guest, Michael Duong, who is a fourth-year medical student at Perelman School of Medicine. Michael, welcome.
Thank you very much.
Michael, you have an MD and a PhD, and you want to do radiology.
Yes.
Tell us why you want to do radiology.
Absolutely. I am very much interested in trying to improve management and care of patients, specifically with neurodegenerative disease. And I think that non-invasive imaging and in the future theranostics have great potential to improve how we care for people with Alzheimer's. That partially comes back to my own family experiences, being a caregiver for people with Alzheimer's. So I would love to give back. And I think that radiology is one of the best ways to do that. Excellent. And you actually have a PhD in bioengineering.
Yes. Did that steer you towards kind of a more physics engineering-based field like radiology?
Absolutely. I really was interested in physics. I actually met with Dr. Schnall when I was an undergraduate at the University of Pennsylvania. And a meeting with Dr. Schnall also very much guided me towards the bioengineering MD PhD program here at Penn. And I think that radiology is a great field because it combines my love of physics and math and machine learning also with clinical aspects that we can be able to help patients.
Well, Mitch, you've been a positive experience impact here, but there have also been, kind of word around the medical student community that radiology should be avoided. So were you not afraid of our jobs being lost to AI?
Yes.
Do you have some questions there?
Absolutely. So there's definitely some concern about that. I know I would be remiss for our listeners, those of who are medical students, not to be able to ask this. The quote from Jeffrey Hinton comes to mind saying that we should stop training radiologists and pathologists because in 5 years there would be AI that would be performing at their level and replacing them. So I'm sure many of our listeners would be wondering, what is your take on artificial intelligence, particularly in the next 10 years, 20 years?
I'll leave that to Mitch to answer.
Well, the line that goes around radiology is, radiologists are not going to be replaced with AI. Radiologists who use AI will be replaced with radiologists. Will replace radiologists who don't use AI. And I think AI, frankly, across medicine is going to be a really important tool. I have to share a story. We met with a senior member of the faculty here who famously sort of supported that quote, Zeke Emanuel, who's well known in policy circles and this had commented that he supported that comment, and we pointed out to him his training is oncology, that what oncologists spend a lot of their time doing is optimizing the chemotherapy regimen, and then we thought that AI probably would do that before it would be able to interpret images, and he reluctantly agreed and said, yeah, I probably wasn't that well posed there. So I think a number of things are happening in radiology that I think are going to, frankly, highlight the importance and need of AI. We're seeing a couple of things. One, the radiology technology that we use has become so exquisite and so good, and costs per exam are going down in terms of they're fast and effective. That more and more we're seeing radiology looked at as the fastest way to a diagnosis. And that's, coupled to the fact that a lot of the people on the front line seeing patients are more and more stressed with utilization going up compared to the workforce that we have to manage it. And so the temptation is to very quickly turn to radiology to get a quick diagnosis, which means that we've got to be able to respond, and we've got to be able to handle a growing amount of radiology utilization that is going to be happening over, I think growing over the next 10, 20 years. And having tools like AI in our pocket, right, to help us be effective, I think is going to be very important. So I look at this not as a risk to radiology. I look at it as our savior, because I think, frankly, without AI, there is no way that we as a specialty can deliver what we're going to be asked to deliver. So I think it's going to be a critical tool for us going forward.
Does that answer your question adequately? Yes. Are you sure?
Yeah.
Don't be shy. Well, I think if I can summarize what you're saying, Mitch, that the use of AI is precisely going to be because the demand for labor is going to outstrip the supply for labor.
Absolutely.
But then the question is, that's going to be in every realm, right? It's not just going to be in radiology. It can be in neurology. It can be in oncology. So why do people think radiology is particularly vulnerable? And for that matter, the opposite question for you, why do you think radiology is particularly resistant, if you think it is?
So I think people perceive it as particularly vulnerable because it's perceived as basically a knowledge business, right? Where you're interpreting images and providing results, where most other specialties are perceived to have a strong patient-facing communication procedure bent to them. You asked about, people thinking about going into radiology and why you do. And one of the things I think that's a big misperception about radiology is that it's a 100% knowledge business. And they underscore the patient interactions, the procedures that frankly continue to grow because, again, our tools are so exquisite that the ability to do image-guided interventions, you mentioned theranostics, Michael, our ability to interact with patients and provide theranostic treatments. Even our diagnostic procedures, many of them are done interactively with patients. So our patient-facing component is bigger than people realize. Any given day, if you look at, and this became very clear at COVID as we were scheduling people, 50% of the clinicians on schedules at Penn in radiology have patient-facing components to their work that day. We know that because we had 50% of them on site during COVID providing those patient-facing activities, whether they're doing biopsies, whether they're doing interactive ultrasound examinations, whether they're doing therapeutic procedures. And so I think that that creates a little more resistance to AI than people realize. The other thing that I think that I think radiology has to embrace, and that is one of the things that we've evolved into is to become sort of the technology masters for imaging technology, and as I'll say, as an extension, diagnostic technology, which has more recently included the computational systems that we use, the PACS systems, the RIS systems, those things. And that's going to be the sort of base on which a lot of the AI applications are going to be driven. And so we've got the opportunity to manage and drive a lot of the technology development and implementation. And I think that that creates sort of a durable position. So I do think that the day-to-day work of a radiologist may evolve, but I think our position and I think that's actually a good thing, because we're now evolving into a very stressed labor force that is trying to make a lot of observations from images in short periods of time because of productivity needs, frankly, because of what we're being asked to do, even if it was independent of the finances, just because people need care. But that to have some of that work transferred into computational systems, with us taking a stronger role in managing those systems and implementing those systems, and something that I think we really have to embrace is figuring out how to do quality control for those systems, I think creates an enduring activity for radiologists.
Thank you. This definitely brings up a couple follow-up questions. So it seems that the takeaway for our listeners and for me is that radiology can definitely be augmented by tools like artificial intelligence. There are different buckets of tasks that can be done. Radiologist has many hats, right? And some of those tasks might be knowledge-based or might have less cognitively demanding roles, maybe like protocoling or something. Mm-hmm. And then there might be different tasks like patient-facing procedures. Mm-hmm. And how do you think, for the first bucket, how do you think that AI might better improve like maybe the less cognitively demanding tasks? Things like maybe lesion quantification.
Well, frankly, as a body imager who sees a lot of cancer patients and has to do a lot of measuring of lesions, absolutely, I pray that sooner rather than later, while I'm still practicing, AI can help me manage those those tracking of lesions over time, measuring of lesions over time, and managing a lot of those tasks for me. I'm very fortunate in a sense that I practice at a large academic medical center with lots of house staff. So many times I have house staff doing that for me, right? And as most academic medical centers, we've outgrown our house staff. So I read about half my cases without house staff. And trust me, I would much rather have an electronic house staff doing that for me than having to do it myself. So I view that as a way to take a lot of what we don't like as radiologists. A lot of people go into radiology for different reasons, or combinations of reasons. Some of it is you love the technology. Some of it is you love the idea of the puzzle, right? Working out the puzzle. I think very few people went into radiology because they want to measure tumors. Chest radiologists don't do chest radiology to measure pulmonary nodules. They do chest radiology to debate what's going on, in the interstitium of the lungs when there's abnormal density and when there's and symptoms. Body radiologists go into body radiology when they see a new lesion and they can debate where it's coming from, and in this patient, given their clinical scenario, what it's most likely to be and what the next step should be. Frankly, you mentioned protocoling. I think protocoling is a really, very intellectual, very much aligns with, I think, high-functioning radiology, because that's fundamental of what we do, right? That's marrying a patient and a problem to a piece of technology in the right way. And I think that's actually among the complex things that we do. Yeah, many of them are relatively rote. They're standard problems, standard technologies. But a lot get to be nuanced. And as I said, I'm a body imager. I do a lot of body MRI. I think, those cases are won and lost at the protocol level. I will often say you do a good job with the protocol with the magnet. You don't have to be a good radiologist to make the diagnosis. You do a bad job with the protocol and the magnet, you've got to be a good radiologist to make the diagnosis.
Thank you. Dr. Jha?
Well, I think you're looking at what has now become the core part of our job, which involves some degree of quantification. I would say that the actual pattern recognition and the integration is maybe 20 to 25% of what I do, particularly in chest and cardiovascular, and 70 to 75% is the quantification. So whilst I agree with Mitch that it would be great to have this taken away from us, I'm not sure how that would change what we do? I mean, if you instantly took away all the quantification that you were doing in chest, what would the chest radiologist do at this? Let's say that this was an instantaneous thing right now, and all the quantification was put into the report. What would be the role of the chest radiologist at that point?
So we struggle, frankly, to get subspecialty chest radiologists to be able to do all the chest work that the health system has, right? So we have to take chest radiology work that could benefit from a chest radiologist and move it into other subspecialists or less subspecialists because we don't have enough chest radiologists. So, I think there's work to do now. You pose a thought experiment, which thank God doesn't happen very often, which is a step function, right?
Yeah.
And of course, if there's a large step function, it's always hard to adjust.
Yeah.
But in truth, there's not going to be a step function, right? There's going to be at least over multiple year, if not decade, evolution of our specialty.
Adjustment.
And yes, and I think there's going to be ample time to adjust and right size our specialties so that we're all practicing in a way that makes sense for us and for our specialties.
So one of the things, if I recall from the lecture I gave to the medical students, which you were there, that you warmed up to that idea, was the idea of radiologists being embedded in clinical decision-making, outpatient clinics.
Absolutely.
So Mitch, how do you see that happening? Let's say, do you see us going back to the ICUs? Do you see us going to respiratory clinics as the adjunct? Do we see us giving consultation to multiple primary care physicians? And if so, the biggest question really is going to be how will that be paid for? And who will pay for it?
So, boy, there's a lot packed into that, what seemingly is a simple question. So, it's interesting. I don't see radiologists physically going and sitting in clinics. The good news is that we've got tools that we can virtually be in clinics without physically being there. And so part of the reason is there's this tension between radiologists, particularly in academia, liking to work in aggregate as a group where they can show each other cases and discuss things with each other, which, by the way, they can do to some extent virtually, not as richly as they can being in the same room, but maybe at some point they could. As well as being close to the technology so they can fulfill that need of supervising and managing protocols on the fly, managing shifts and protocols that need to happen, alongside of their technologists and having that relationship with their technologists. That being said, I do think that the tools that allow us to virtually be present are going to be very important. And I think we are already, becoming a more powerful voice in the decision-making process of what happens to patients, and for any number of reasons. One is our technology's that good, and continues to get better in terms of what we're able to see and what we're able to do. The other thing that's happening is those that are asking us questions, that are referring examinations often. Now, I'm not talking about the super subspecialist, neurosurgeon, but most physicians that are asking us questions, they're under a lot of stress and strain. They're under a lot of productivity pressure themselves, and they need someone to help them make these decisions and help them guide what the patients do. The other thing that we're seeing, frankly, is we're seeing not only are they under stress and have less time, but often they have less training. We're seeing more and more APPs. We talked about the workforce in radiology. Well, the workforce in other specialties is similar, right? The workforce across medicine is under strain. And one of the ways to augment that workforce is to bring in APP providers. And the APP providers don't have the medical experience that physicians do, so they've got to rely more heavily on radiologists, and frankly, more heavily on radiologists, not just to get a diagnosis, but to learn about what the next steps are for patients. So I think we're already gaining a stronger and stronger voice in management of patients. I'm hopeful that we'll continue to use the tools that are available to virtually be present in many of those settings that you suggest. But I don't know that it's a great idea for us to divide our workforce into piecemeal workforce into outpatient clinics for lots of reasons that you intimated, whether it's productivity, but I think also from just culture and how we like to work and how radiologists like to work.
Can I also ask Dr. Jha, you gave a great lecture for our Radiology 300 class, kind of talking about potential new roles, potentially more patient-facing roles of radiologists with the evolution with AI potentially offloading some of the workload. And you've written extensively about kind of the radiologist as a domain integrator, looking at like a chest imaging, but then like scrolling up, looking at the neck and seeing all the way up to the cerebellum, for example, in one paper. What is your thoughts on an integrator in this world of hyper-specific specialization and then potential like more patient-facing roles?
Yeah, so I think Mitch remembers this legend as well, perhaps more than me, Wally Miller Sr. So I remember there was one occasion when I remember Wally Miller Sr. was quizzed about a chest X-ray, and the patient had a suspicion for pneumonia, but wasn't getting better. Mm-hmm. And he put the chest X-ray, well, it was actually on PACS. X-ray was on PACS. He just kept listening to the story, and he said, "Have you thought about epidural abscess?" Mm-hmm. Which is what the patient ended up having. Mm. So his expertise, in many ways, the imaging was just incidental. He just had a very strong knowledge of clinical medicine. So the integrator is a good model. It harkens to the past. So in a way, it's one of those futuristic models that's actually very orthodox. Mm-hmm. And essentially, what you want to do with that is you want to think about the body as a disease more systemically as opposed to piecemeal, which we tend to do as we become more and more specialized. That's certainly a way to practice radiology. It's not incentivized presently to do that. Mm. One almost has to do that out of their own volition. I don't think we're necessarily trained to do that. Mm. And the most important thing is that given the productivity pressure on radiologists, there's very little time to be the integrator of information. Okay. Which is where I think there is an opportunity, Mitch, isn't there? I mean, I think if a department, big academic department like this one, creates this kind of a workforce, I want to call them Naval SEAL radiologists, whose job it is on a certain number of patients to put all the information together, all the imaging together and all the labs together, and do all the stuff that is non-patient facing and come up with some sort of summary statement. Do you think that is something that you foresee happening?
So I think yes, and I'll argue to some extent it happens today. So, I think that at least that may not be the case in what I'll call some of the lower technology exams like chest x-rays and things where, the numbers are high, the turnaround expectations are really very short. And there's not a ton of time to go rummaging through the medical record to go integrate information together. Mm-hmm. On the other hand, a lot of the higher technology cross-sectional imaging, and as I've said a few times today, I do body imaging. Most of my work is cross-sectional imaging. The majority is MR, and we are very commonly rummaging through the medical record, finding what other images are done, looking through prior PETs, looking through prior CTs, looking through prior MRs, looking at tumor marker studies, looking at, a series of things across the record, what therapies the patients had. I actually spend more time in the medical record than I do with the images in the typical patient, exam that I interpret. One of the places AI, I think, will help us sooner rather than later is going to be that process of rummaging through the medical record, right?
Sure.
Very quickly, I know a little bit about the patient's context, and I know the things I want to know, right? But it's not so easy, even knowing the things I want to know, to find them all. And I think being able to organize the record, which is generally organized by event, right? It's an event-oriented record, to sort of a medical problem-oriented record, which I think some of the interpretive and computational tools will allow us to do, and people are working feverishly at trying to do this more accurately. I think it's going to enable that more and more. But it goes on to a fair amount, I think, in strong academic departments. It's one of the biggest differences when I look at often reports that come from more community-oriented, less subspecialized. It's clear that they don't have the time or feel empowered. Maybe they don't have the medical expertise. They have the imaging expertise, but not the medical expertise to understand the records at those levels, that you don't see a lot of that integration happening.
Mm-hmm.
So that's kind of integration for the particular study.
Yeah.
What about integration as a whole for multiple studies for a particular patient and rendering kind of a informational summary that combines RAD and PATH? Because at the moment what happens is if you look at the electronic health record, you see multiple diagnoses. Sometimes you'll see something like EGD, NOS, all of these acronyms. NOS, I think, is not otherwise specified. And it's hard to know the vector of a patient's course. The biggest example I face, one of the examples I face, is that often just knowing that the patient's on a drug like amiodarone helps a lot when you look at pulmonary findings.
Sure.
And to know that somebody's on amiodarone, first I have to use certain heuristics, one of which is if there's a big heart, then it's quite possible that they might be on amiodarone. And then if they have atrial fibrillation or some sort of arrhythmia.
Yes.
But it takes me 4 jumps to come to that. And I think that the way that in the past great primary care physicians used to do a succinct summary of the patient's medical history, do you think there's value in doing succinct summary of the patient's informational history?
Absolutely. I mean, I think you touched on 2 issues. One is creating a succinct summary of somebody's medical history, and I'll even go one step further, and classifying their context, right? So somebody shows up to an emergency room and they've got liver disease. Well, it's important to know, do they have early liver disease? Do they have cirrhosis? Do they have cirrhosis with HCC? Do they have cirrhosis with HCC that's been tased and treated in multiple ways? So that right away, just knowing that context is, instantaneously tells me a lot. If I'm an ER doc, if I'm a radiologist reading another study on them, if I'm anybody, sort of what I need to do with them, right? And so I think that type of summary is important. The next level of taking a step back and looking across the entirety of the patient's record and thinking about, particularly those that are undiagnosed, which, may be a minority of the cases we see, right? Because most of our patients are patients that are undergoing therapy for most of the diagnoses we know about. They may have new symptoms which are undiagnosed, but for those patients undiagnosed, I do think that there's a role for that. And the easier we get access to be able to integrate that information, the better we'll be. You asked about who's going to pay for it. And, I think we're going to be sitting around this table again once speaking about, value-based radiology. And more, healthcare is shifting risk onto the provider and going to value-based care models. And so ultimately, it's going to be incumbent on us as radiologists working in concert with our systems to be able to show that there's value. And we have to we'll talk a little bit about this when we talk about value, but we have to be careful how we think about value, from whose perspective. And at some level, it's got to be from the cost perspective, right? Because it's got to be sustainable. And if we're going to invest time in an activity, we have to show that's a sustainable investment in that cost. And so faster to diagnosis, being able to provide more efficient care to avoid acute care episodes, things that everybody will agree will ultimately be beneficial, not only to the patient, but from a cost and from a payer perspective, are things that are going to be the easy wins.
Thank you, Dr. Schnall. So the future of radiology will definitely involve evolution of our understanding of the idea of value. And this somewhat relates to the prior podcast on scaling up radiology or increasing in volume, or radiologists also adding different forms of value. Dr. Jha, you've also spoken about the idea of radiology as a consultant service. Maybe, for example, nowadays there are patients with multiple sclerosis who come in for their interval imaging of their brain and spine, and the management that the neurologist provides is very much driven by what the radiologist sees. Or similarly with tumor surveillance for patients with oncologic problems. Do you see, for both Dr. Jha and Dr. Schnall, do you see the idea of radiologists adding value as a consultant?
To the
what
patient?
that might look like? Yeah.
Yeah, I've kind of swung like a pendulum. In the first few years, I was very much radiologist is a doctor's doctor. And that's why I went to radiology, is because I saw the limitations of diagnosis being on the other side of the fence. And I said, well, one day I'm going to help my colleagues make better diagnoses. My story isn't that heroic, but it makes sense if you think about it that way. I think, I know that we're at Penn experimenting with a lot of these things in the Center of Innovation, led by Dr. Cook and colleagues. And essentially, you have to be very careful when you're disclosing anything to the patient, unless you have a full context of their history. So you have to be careful that you don't oppose what has been said to them by their clinicians. But I think there are certain circumstances where you can speak to the patient because you have pretty good knowledge and where context isn't going to be that important. So a few things just off the top of my head. Number one, lung cancer screening CT.
Okay.
Purely driven by imaging. Oh, yes, of course, pretest probability, but that's what gets them in the first place. So the smoking history gets them, and thereafter, it's pretty much down to the imaging. The nodule, the shape of the nodule, the background lung, et cetera, et cetera. So 100% we can talk to them about that. Incidental findings, whether or not we should pursue them or not, either way, that kind of shared decision-making, that's another big area. And the third is something like a screening for cardiovascular disease, like calcium CT. Now, in reality, the nuances of the pharmacotherapy will depend on the cardiologist, but there are a few things you can say as a radiologist. I mean, you can say, hey, look, you have calcification. You know that New Year's resolution you had of going to the gym, you might want to actually go forth with it.
I think all of us.
And things that get quite complex are oncological studies, where they're on multitude of drugs and where there may be an increase in lesion size or reduction in lesion size, but overall the decision making there would still be the oncologist. Mitch, what's your take on speaking to the patient?
Well, I mean, I think, again, it's context specific, but I think there shouldn't be any sort of rules or challenges to our speaking to patients. I mean, we do in many instances, right? We do routinely in breast imaging. We do routinely in the ultrasound suite, as we're performing ultrasounds. We do as we're doing ultrasound-guided procedures, speak to patients and interact with patients about their disease, and they talk to us. Patients are commonly hungry for information. Their visits with their clinical teams are often limited because the teams, everybody's pushed. They have a lot of patients they're caring for and have limited time. The one thing I'll caution, though, that in the traditional fee-for-service world, patient-facing conversations and consultations are not highly valued. And so radiologists may all believe that this is what they want to do, and that's where they want to spend their time. But in a traditional fee-for-service world, you don't get a lot of value back for that. You get a lot of value back for the procedures, for interpreting an exam, for doing a procedure, but not for spending 20 minutes or 30 minutes on the phone in a televisit or, frankly, in person with a patient. So I just think that we have to balance everything, and frankly, medicine is all about balance in the end. And so, but I don't think there should be any prohibition about interacting with patients. And think it should be part of what we do.
So that's. I'm glad you mentioned that. The opportunity cost for speaking to patients, which sounds a little kind of almost capitalistic. It actually is.
It is capital. What do you mean sounds like?
It is capitalistic. but there are certain things that one does to improve the productivity of a department, and there's certain things one does to sustain the profession in the long run. And the reality, which is kind of like a tragedy of commons, is that those long-term things that one puts their mind to aren't valued and therefore are not done to that same extent. So here's the challenge. So you have, you want to introduce this activity, but you don't want to overdo it. You want to encourage it, but you don't want people giving up their, day jobs just to do this. How would you, what kind of mechanism would you propose that you would introduce this consultation service without, with sufficient incentive to or reward to the patient doing it, for the radiologist doing it, without, getting them completely away from their usual clinical duties?
Well, it's interesting. We did a pilot a few years ago where we, in a subset of our department, we put on the bottom of the report the name and contact information for a radiologist, and basically soliciting the patient if they had any questions, they're welcome to call. So we're asking them to have those conversations. And there was no charge for those conversations. The interesting thing is that there were calls and there were discussions, but it was a fairly low number compared to the number of procedures that we performed. And so I think most patients are going to be satisfied with their report. They'll be satisfied with their report and the interaction they have with the rest of their clinical team, because that's who they know and they're comfortable with. There'll be a minority of patients who may want to have further conversations. And so, it may be that a model of, selecting that minority, allowing them to self-select, might be a strategy to both hit the patients that are going to be, most impacted, as well as, manage the utilization. I think to go out and be over-solicitous here, for reasons we just talked about, may not be the best idea.
Yeah, no, that's certainly a reasonable interpretation of that study. I would say that these sort of things, it's not so much of fulfilling a need, it's about inducing a demand. It's the whole cardiac CT in the emergency department.
Yeah.
When it's there, it'll be used. If you build them, they'll come. I just wonder how much there would be a demand if the radiologist started speaking to the patients pretty much instantly after their scan, showing them images on their fancy volume rendered projections. But I want to get to one thing which I've been wanting to get to earlier on, based on what Mitch said about the expansion of physician assistants and non-physicians in other areas. That's actually going to have a huge secondary impact on radiology. I'll give you an example. A few days ago, there was a APP who ordered a CT angiogram of the abdomen pelvis to look for mesenteric ischemia versus GI bleed. Based on that person's assessment, that's what they thought the patient had. It turned out the patient had perforation. It's free air and perforation. And the first conversation we had, we said there's perforation, noted it, documented it, you know, how people discussed with and acknowledged by, et cetera, et cetera. And then I thought, well, hang on a minute, let's just ensure that my understanding of the gravity of the situation is the same as theirs. So I phoned back, said, well, you know, I think you need to get surgery because this patient essentially needs a laparotomy. Oh, okay. And then 20 minutes later, the surgeon was phoning. So this was all, up till now, the whole management, the only physicians were the radiologists. And it's going to be something of extreme irony if in 10 years from now, the only physician standing, the last physician standing, is the person behind the view box.
Well, I mean, so I think it is more common than you think in our emergency rooms that the only physician involved in a patient's care, right, directly, is the radiologist. I see that not infrequently. And you know, for reasons we talked about earlier, you know, they are very quick to use their diagnostic tools. They're very quick to use radiology, and in part, and I would argue even the flip side, right? Our ability to do what we do, frankly, empowers their ability. They couldn't function in an ER. You couldn't have an ER functioning the way it does with, you know, driven by NPs and PAs often, without radiology doing what it does, right? If there wasn't an abdominal CT, a head CT, they couldn't do their job.
Yeah, and in fact, there was a study by a couple of radiologists from the Radiology has a Health Policy Institute known as the Harvey Neiman Health Policy Institute. A couple of researchers, I think economist Danny Hughes, published in JAMA IM a few years ago, where they showed that in primary care, the APPs use more imaging when you risk adjust compared to. Now, there's a lot of people have very strong views about APPs, and
well, when I talk to one of the local insurance carriers, they'll tell you that even though they pay an APP primary care provider less than a physician, it costs them more to care for a patient with an APP primary care provider because of utilization of resources around them.
So that's one of those, you know, it's the way the world is.
Yes.
Kind of, you know, the descriptive situation.
Well, there's not enough workance.
Yeah, there's not enough work. And the alternative to that is creating more physicians, which creates its own issues. Like, I mean, you can mass produce a lot of radiologists, theoretically, but in practice, it's not that easy because who's going to train them? We are already at Penn, the number of trainees are already at Penn, stretches the ability of people to teach them, even if they were pure apprentices. So I think your initial questioning was on the future of radiology, whether it's sustainable and viable. And I think that there are a bunch of things that would make imaging increase in volume.
Yes.
to such an extent that even if you nipped off 20% of that growth, you'd still have plenty of work for the radiologist.
I would argue you would nip off 50% of that growth.
You still have
Oh yeah.
50.
Oh yeah. I think we're at the very beginning of what's going to be an exponential growth for two reasons. One is the aging population and the population becoming more, asking for more utilization. And another facet of that is we're being successful in turning a lot of what used to be lethal diseases into chronic diseases, right? That's the old mantra in cancer, right? Make it a chronic disease. Well, now we've got these people used to not be in the medical care system, soaking up lots of resources and getting lots of radiology utilization. Now they are, and they're super high utilizers. And then on top of that, we've got a less and less empowered patient-facing component of the medical establishment that needs us more. And you put all those things together, we're seeing utilization go through the roof, and I think we're on the early part of an exponential growth.
Yeah, and I think in many ways, we're actually witnessing it in oncology because you have all these patients on these fancy drugs whose names I never can remember, but they all have the same sort of stuff that people without those fancy drugs have. So they have myocarditis, they have pneumonia, and they have PEs. They have pleural effusions. They have all stuff that can cause you dyspnea, so or other symptoms. So you
absolutely.
So whatever the the range of pathologies were pre-cancer are now the same range of pathologies post-cancer.
Absolutely.
Because now the cancer survivor is alive. Yeah.
And on top of that, they also may need more imaging for surveillance, for treatment response, detection. So,
but a lot of them are immunocompromised.
Yeah.
Their physiology is compromised in other ways. They've had surgical reroutings of things that make them vulnerable. And so, if you look at the average, chronic cancer patient as an example, you'll see just as much, if not more, imaging done for their intermittent emergency room visits and other visits for their acute spikes in problems than you will for the surveillance of their cancer, right? And that happens sometimes for 5 and 10 years because we've been successful in turning that lethal disease into a chronic disease to a large extent. Same thing's happening with a lot of heart failure patients, same thing's happening with liver failure patients, renal failure patients. And so we're creating, and we see that this is a tertiary care medical center problem, maybe more than a community problem. Yeah. But we're seeing a huge amount of utilization of all healthcare resources from this. And so there are a lot of things that are driving this. It's not one thing.
That's very encouraging. And the summary from Dr. Schnall and Dr. Jha is that radiology is having exponential growth, and that if there were other tools, other services like AI that can relieve some of that pressure up to 50%, there would still be more than enough work for human radiologists. So that seems very encouraging for the listeners.
Yeah, and I'm not even certain if I will give you kind of a more generic term for that. I would say that information is increasing.
Yes.
The amount of information that is out there is increasing, like entropy.
Yes. Second law of thermodynamics.
Yeah, so there must be an informational version of that. Now, we're certainly hoping that AI will nab, as Mitch says, 50%. My guess would be 20% of what we do. But it's also possible that AI will actually increase the amount of information we have.
Sure.
Because it will give us predictive information. And now there's a whole field, radionomics, where the feature of a tumor or a lesion on CT is analyzed with AI with much more granular information.
Yes.
So somebody has to make sense of that. And the task will fall initially to the radiologist. So I don't think that it's going to be... So I wouldn't be worried about a job to people. There was a time when people were worried what's going to happen to radiology and whether or not we'd end up flipping burgers Although if my job was taken, I'd go into palliative care. I'd retrain in palliative care and become a palliative care physician. But there is one thing that there are a few trends, I'm not sure Mitch would agree with me, that I want to caution about.
Mm-hmm.
To give you a little bit of a kind of a backdrop on this, I have noticed when I gave the talk this year, a large number of first medical students on that course. It may have been random, coincidental. Also a large number of people interested in radiology. And also nationally, there's a larger number of people interested in radiology.
Sure.
Radiology is very elastic. So the job market often determines what medical students think. Maybe perhaps not what you're thinking, but a lot of other medical students think. But one other trend which is presently pleasing but could backfire is the fact that we can essentially read from home in our pajamas. We can be in Colorado, we can be in Nebraska and be reading for Penn and Hopkins. And this has definitely helped academic medical centers. But Mitch, do you think this is going to backfire? Is it going to be a problem, or are you looking at a two-tier system?
I think if we don't manage it well, it will. I mentioned before, a lot is about balance. This is about balance, right? Right now, almost every medical center, community or academic, has need for some number of ongoing studies to be read so that, it makes an easier and more sustainable position for those that are on site. And that can be done with other on-site radiologists. That can be done equivalently with off-site radiologists. And so to have radiologists off-site as part of the team, I think is a good thing. It allows some balance in the specialty. Many of our radiologists downtown are able to work from home a day a week, as an example, which they love to do. But I think it has to be balanced, and we can't give up a lot of what we do that requires us to physically be part of the team. And so managing that balance is going to be important. But I think we have to recognize that there are those people that seek positions like that, and if we can, it's not easy. Different medical centers have taken different ways to structure those kinds of positions so that people who come to work every day aren't asking, why am I the sucker that's coming to work and not working from home? So we've got to structure things appropriately. Yeah. And we've worked very hard to do that. Maybe not, optimally, but we keep working to do that. But I think it's about balance, and I think there's room for it, but there's not infinite room for it.
Yeah, and its popularity is concerning because it means that it kind of becomes you got to give me the freedom to work from home. I mean,
we're seeing that already.
I'm concerned about it because I'm concerned about losing that community.
Yeah,
sure.
Even on the weekends when I can work from home, I come in where I can, which is most of the time. But I can see it's a slippery slope. So we're coming to the end. It's been a great discussion, but I want to end with a question to all of us, including myself, but I'll start with you, Michael. So I understand why you want to go into radiology. It's a combination of your desire to make a diagnostic difference with your love of technology. What is your expectation in the first 2 years of residency that would make you believe that you made the right choice?
That's a great question. First 2 years of radiology residency, including the internship.
Oh, let's take the internship away. That's a necessary evil, but let's take that away.
I think that being on rotations that I enjoy, being able to catch things, make diagnoses that can really change the management of the patient in a positive way, I think would be very fulfilling for me. So I look forward to being able to learn what I can on all the different rotations and services.
So essentially, you want to see that your report influenced management. Like, the car was going east, you told them to go west, and that was the right decision.
Yes.
Mitch, at what point did you want to do radiology, and when did you feel that your expectations were fulfilled?
Well, similar to Michael, I came through the MD PhD realm with a PhD in biophysics and very interested in the technology. I loved patient contact as a medical student. I loved doing procedures. I loved being in the OR, and fretted quite a bit with the decision. But I was heartened by what I saw as a strong patient-facing component of radiology, and strong procedure base in radiology. Everybody points to IR, but in fact, every subspecialty does procedures, at least in our department. I was convinced I was right early in residency because I got exposed and had opportunities, to be patient-facing, to do tons of innovative image-guiding procedures, to interact with technology in ways that was fun, and so that it was the combination. And frankly, it served my ADD well, allowed me to do something different every day, right? Instead of doing the same thing every day.
Yeah, and I think you, I don't want to put too much of an age gap between us, but you come from an area where you're actually at the scanner, right?
That's correct.
Actually, partly I was also at the scanner initially with cardiac imaging. So for me, my course was slightly different from both of you, whereas you came in with this technical expertise, almost like biophysics, bioengineering. I started off in surgery in a different continent with paucity of imaging and with a lot of diagnostic delays, a lot of laparotomies that were negative, a lot of laparotomies that were too late, appendicitis that wasn't appendicitis. So I always thought, let me do something that will help my clinical colleagues be better doctors. And to me, I realized that I was pulling that off, although perhaps not with the same amount of happiness that I might have wanted, around 2 a.m. on ER call during being a second year resident. Because that's where you see maximum uncertainty. And that's when you tell people, this is what the patient has, and they say, are you sure you're talking about that patient? Because at some point, HNP has a limit.
Yes.
And it's when you're at that, event horizon where the white cell count isn't elevated, where, the pain is a little bit disproportionate, but not too disproportionate. You come up with something, or you basically say to them, there's nothing, it's negative. Both situations, I think. So yes, it's mostly a very rewarding field, but there is some automation. Well, thank you very much to both of you, and Michael, I wish you all the best in your career.
Thank you.
And your match.
Thank you very much.
Mitch will be back with some more value-based prodding, and I hope this podcast is heard by medical students contemplating radiology, because I can tell you that neither Mitch nor myself were ones to say things that we don't believe. So if we believe radiology has a future, then that must be what we believe. Absolutely. You heard it here. Yes. Thank you. And thank you for listening to Keeping Up With The Radiologists. Back with another episode. Goodbye for now. Thank you for listening to Keeping Up With The Radiologists, podcast from Penn Radiology. Please subscribe to our podcast, and if you like it, share it with your friends, pass a comment, write a review, and just simply say you like it. Thank you again.